Hello, I'm Dr. Mohammed. I'm one of the doctors in the medical clinic for today. May I confirm your name and age, please?
Yes, doctor. I am Salma Hamid, and I am 34-year-old.
Nice to meet you, Selma. So we're here today to discuss some issues related to your health. Is that okay with you?
Yes, doctor.
Okay, during our meeting today, I might need to take some notes. I would like to reassure you that I will give you my full attention and to be completely confidential. Is it okay with you?
Yes, doctor, sure.
Okay, so can you tell me, I can understand that you have some tiredness and low mood. Can you tell me more about it?
Yes, doctor. In the last year, I'm always very tired, and I start to feel that all the time. I can't do my work as before. When I stand up for minutes, I feel very tired. I'm not as before at all, and this start to affect my performance at work and at home as well. I don't know what to do. I tried many multivitamin, and I went to my GB many times, and I'm still feeling this tiredness all the time. And this really start to affect my mood badly. So
I'm really sorry to hear about that, Salma. So basically, was it all of a sudden?
It started gradually, doctor. I feel it started gradually, but to be honest, I would say it was mainly after after I gave birth for my first baby, and since that time, I never get back to what I was before.
Okay, I'm really sorry to hear about that, Selma. We're here to solve all your issues, okay? So basically, you said it started gradually. Is it getting worse over time or it is the same?
Yes, doctor, I felt, yes, it's getting worse. Yeah, it's getting worse.
Okay, and you mentioned that you feel tired all the day and with a small activity that you are getting tired. Am I right?
Yes, doctor, I always feel tired, yes.
Okay, and is it the first time to have such symptoms, Selma? Like tiredness and low mood?
Yeah, this year. Yes, this year. Before I was known to be very active. It was like one of my known characters that I'm very active and I was multitask person, but I'm not that anymore.
I can understand how this might affect you, Selma. So basically, can you tell me, you said that you had those symptoms after you got pairs after you delivered your baby. Can you tell me, when was that exactly?
Yes, this was 1 year and 2 months, 14 months from now, I gave birth. And after that, maybe 1 month, it was fine, or 1.5 months. Then I start to feel tired and this problem started. And this really made me very down all the time.
Okay. So may I ask you, how was the delivery for your baby?
It was normal. Everything was normal, and no problem happened.
Okay, so it wasn't complicated, and you didn't have any bleeding or you haven't lost any blood at that time.
No. It was like normal one.
Okay, and how is the baby?
Yeah, he's fine.
Okay, and have you been able to breastfeed him?
Yes and no. I would say yes in the beginning, but then because I felt that lactation and breastfeeding make me more tired, I'm trying to mix both the breastfeeding with the bottle feeding.
Okay, I can understand. Okay, and you said that you have low mood. So basically, is it came after the delivery as well with the tiredness?
Not exactly. I mean, it didn't start immediately after giving birth. I would say 2 months after that or 3, because I think it is related to being tired all the time. I feel that I can't cope with any of my responsibilities. So this should be the reason of my depression, I think.
Okay, I can understand how hard those things for you, Selma, but be sure we're going to manage all your symptoms and to treat you as well. Okay, so basically, can I ask you, have you noticed any weight changes?
Yes, doctor. Yeah, it's one of the things. Yes, because I can't do my regular activity. I can't exercise anymore. I noticed that I got about 9 kilograms in the last year, and this also distort my style. I can't wear my clothes. I can't. I'm hiding myself from the community, from my society. I don't want them to see me in this mood and in this size as well.
Okay, I can understand. And have you put weight all over your body or a certain part of your body?
It's all over my body, doctor.
And what about your appetite?
My appetite is not. It's not good, doctor.
Is not good. Okay.
Yeah.
And have you noticed have anyone commented that you're paler than usual?
And what paler? No, I noticed some paler, but not that much.
Not that much. Okay. And do you have any lumps or bumps in your body?
No, doctor, not really.
Any high body temperature?
No.
Any night sweating?
No.
Okay, okay. And then, Selma, can I ask you, how about your sleep?
My sleep also became very bad recently, not recently, even over the last 6 months. I never sleep well. And I noticed that I wake up many times at night. And even my husband told me, why you are like getting up suddenly from sleep. And
Mm,
I'm also shy that he also told me that I'm snoring loudly
mm.
lately. Yeah.
Okay, I can understand. And have you noticed any headache at early morning?
Yes, doctor. I always had a headache in the morning in this year. Yes, you're right.
Okay, and have you noticed this headache getting worse with coughing, sneezing, or bending forward?
No.
Okay, okay. And then, do you have any refreshing sleep from what you have told me? Is that
Uh,
the case?
I don't feel sleeping making me better now. I'm always tired and sleepy.
Okay, and have you noted that you're sleepy during the daytime?
Yes, usually I need to do that. It's part of my tiredness measure.
Okay, I can understand. And have you noticed any weather preferences?
Uh, I would say yes, because I can't tolerate the air condition that we used to put
Mhm.
usually in our home. So yes, I'm always trying to be covered. I'm always trying to make and this is something also annoying my husband because I
Okay,
always want the weather to be more on the warm side.
okay, I can understand. Have you noticed any hair falling?
Yes, doctor, my hair is not as before. They told me that this was related to my pregnancy, but even after pregnancy, I still losing hair.
Okay, I can understand. And have you noticed any change in your bowel habits?
Yes, doctor, I have constipation, hard stool, and this start also to make problem to me because I start to have piles, and I would never used to have that.
Okay, I understand. And how did you manage to manage your hard stool? Are you using anything to help you
Yeah,
out with it?
sometimes yes, I'm using laxative and stool softeners, and I'm trying to drink more water as much as I can, as advised by my GP.
Okay, and have you noticed any blood from the back passages or dark stool?
No, doctor, but I can feel something protrude from my back passage.
Okay, and may I ask you, do you have any difficulty in combing your hair?
A little bit in the last few months, 3 months, I start to feel pain in my upper arm when I'm trying to comb my hair.
Okay, and any difficulty in standing from a sitting position?
Yes, doctor. Yes, I also noticed that. Thank you. It seems like you know exactly what I'm suffering from. Thank you for that.
Okay, okay, thank you. So, have you noticed any swelling at your neck at all?
No, doctor.
Okay, no worries. And have you noticed any difficulty in breathing?
No,
Any difficulty in breathing when you lie on your back?
no,
Any heart racing?
no.
Okay, and any chest pain?
Just been no,
Any cough or coughing up of blood?
no,
Any noisy sounds?
no.
Okay, and any heartburn?
Not really. Sometimes, doctor, when I eat just before sleeping, I get that at the morning.
Okay, okay. And have you noticed any acid brush?
Sometimes at the morning.
Okay, okay. And any difficulty in swallowing?
Difficulty in swallowing? No, doctor.
Any tummy pain or swelling?
No,
Any change in your water work?
no, doctor.
I mean, have you noticed any increased frequency or
No,
change in the amount?
no,
Any change in the color?
no.
Okay, and that's fine. And have you noticed any weakness in your body?
Weakness, as I told you, my upper arm. I feel my arms are more weak and my legs as well.
Okay, understand. Any change in sensation?
No, doctor. Almost normal.
Okay, any steadiness on your feet?
No,
Any blur in your vision or change in your vision?
no,
Okay, and have you noticed any joints pain or swelling?
no, doctor.
Any skin rash?
No.
Any skin changes at all?
I feel my skin is more dry than usual,
Mm,
though. Yeah.
okay,
2 minutes
okay.
remaining.
Oh my God. Okay, okay. So, do you have any previous illness you should be aware of?
No, doctor. As I told you, I used to be fine. I used just to use my multivitamin.
Okay. Have you had any operations or blood transfusion before?
No, it was just uh, the delivery, though. It was vaginal delivery.
Okay. Any family history of any illnesses should be aware of?
Uh, my mom had a gland problem, but I can't remember what was that.
Okay, understand. Okay. May I know what is your concern?
Yes, doctor. I want to know what's going on, and I'm very worried if I have serious thing because I start to feel that I had serious hidden cancer or something that might be causing this tiredness. And the other thing, I want you to give me something to reback my power if possible, because I want to go back to my normal life.
Okay, before I answer your concern, may I ask you one question? Do you have any dizziness or dizziness when you stand from a sitting position?
No, doctor.
Okay, so Miss Selma, I highly appreciate your concern. From what you have told me, I would like to examine you thoroughly, but I have one thing in my mind causing the symptom that you're having. Most likely you have a condition called postpartum thyroiditis. It's a condition in which there is a decrease in production of a special protein produced by the gland at the front of your neck. It might cause all the symptoms that you're having. So basically, what we need to do some blood tests and some images in order to confirm the diagnosis. Okay, and regarding your question that can we give you some medication? Yeah, it's treatable condition. We can give you some medication that might help your symptoms out with this. Do you have any other concerns?
No, doctor. That's it.
Okay, other thing, Selma, that you're having obstructive
So
sleep apnea.
don't you think it's cancer, doctor?
It's cancer is the less likely possibility in your situation. I would like to reassure you that. Okay, so with your condition, do you have another condition called obstructive sleep apnea? It's one of the complications of the increased weight gain. So I would like to advise you to stop driving for the time being if you're driving, Selma. Okay?
Okay, doctor. Time finished.
Okay, that's fine.
Okay, thank you, Dr. Ryan. Am I pronouncing your name in the right way, Ryan?
Yeah, you're right. Thank you.
Thank you. Okay, doctor, so thank you. In this step, usually what we do, we have the other candidate giving you their expected score. You won't see that. I'll be the only one who see that. So I can get an idea about the evaluation of the candidates for your performance and their understanding of the scoring. So can you please, doctors, give Dr. Ryan your expected score out of 20? Okay, so there's one doctor give you 22 out of 20. It's okay. And others some give you 18, some give you 19, 15. So first of all, congratulations. Most of them give you a passing score.
Okay, thank you.
And thanks God, these are not your examiners. You are very tough guys. They're giving you very tough scores. Okay. So your scores, what they give you is between, only one give you less than 15, but the others between 15 and 20. Okay. Two doctors one give 12 and one give 14, but the others give you between 15 and 20. And I won't give you my expected score until you answer the examiner question. Okay.
Okay, that's
so now let me start the timer for the examiner questions. Okay. Okay, doctor, what is your differential diagnosis for this patient?
Well, my top differential diagnosis for this patient might have postpartum thyroiditis, basically postpartum hypothyroid state with obstructive sleep apnea. Other differentials might be postpartum depression as well, and other differentials might be other causes for hypothyroidism, like Hashimoto's thyroiditis.
Yes, great. What are you going to do for this patient?
I would like to do basic and specific investigation, basic in the form of complete blood count to look for the hemoglobin and to look for the MCV of the patient. I would like to do inflammatory markers, CRP and ESR. I would like to do renal function test, liver function test, and coagulation profile. A specific investigation, I would like to do thyroid function test, TSH, T3 and T4. I'm expecting that T3 and T4 would be low with high TSH.
Any other thyroid test you want to order? Something related?
Yeah, I would like to do thyroid autoantibodies like antithyroid peroxidase enzyme and anti-thyroid stimulating hormone antibodies.
Okay, great. Would it make any difference if you know if the social history of this patient in general?
Yeah, it will help me a lot.
Yeah, with the mood disturbance, and having the history, having more details about social history, don't you think it would be helpful?
Yeah, of course. If I have a time, I would ask about if she has support at home and if she had any social issues before this.
Any previous abortion will help you or not?
Yeah, of course, it will help me a lot. Of course.
Okay, doctor, what will be the any other investigation you want to do for this patient?
Well, I would like to do morning cortisol level just in order to exclude associated autism disease, although it's a less likely possibility. And I would like
You
to
need
do,
a sleep study for this patient?
yeah, I need to sleep study as well. And I would like to do a chest X-ray, ECG, and echocardiograph as well to see if there's any
What do you
complication.
expect to find in the echocardiogram?
In the echocardiograph, I might expect to find features of pulmonary hypertension as a complication, like dilated right side and increased pulmonary artery pressure.
And do you expect, don't you think following the blood pressure will be important as well for this patient?
Yes, of course, as it might be complicated by hypertension and arrhythmias as well. So it's very important to measure the blood pressure and to follow up the blood pressure as well.
Thank you, Dr. Ryan. Thank you. Okay, tell me, did you feel any stress while practicing the case?
A lot of stress. I was
Yeah.
stressed out, and the
Okay.
main thing is that I didn't have enough time to go through the social history and work history.
So
And
you need to speed up a little bit, right?
yeah, I believe so.
Yeah.
Okay. Yeah.
But
Thank you.
general speaking, you did great. Okay, you did great. You reached the perfect need diagnosis. You went through everything needed. You gave a good, nice management plan as well. And your approach was great. So just to know, as an examiner, you will get almost full mark in this station. So for the doctor who gave you a very bad marks, this is not true. Doctors, don't overthink about what you should do and what you shouldn't do, because eventually in the history station, if you reach the need diagnosis, if you went in a logic pathway and you get a correct answer for the patient, you will definitely get near the full mark or the full mark. So please don't be tough on yourself. Okay, because this will make it hard for you to practice any case. So what Dr. Ryan did was almost perfect. She reached things that might be missed, because what happened in the real exam was the candidate forget whether they forget the obstructive sleep apnea. They got only one diagnosis. Some of them didn't even reach that. So what she did was perfect for this particular case. And I like your confidence. I like your voice tone, because yes, your voice showed some sympathy and empathy about her condition because she is suffering. Some evaluation of depression was a little bit missed here, because when you have depression, Dr. Ryan, you need to evaluate the depression, right?
Yeah.
It's important when the patient with depression, because of the risk of what? For female in that.
Suicidal attempts. Yeah.
Yeah, so it is important. Okay. Thank you, Dr. Ryan. Thank you. Did you enjoy the case?
Yeah, it was so fun. Thank you so much. I enjoyed it. It
Awesome.
was a bit challenging because initially I thought about, oh, she had it after she got a baby, so it's most likely Sheehan syndrome. And then, oh, boom, out of things, no, she breastfed her baby very well, and the delivery was fine. So yeah, it was
Great.
a very good case. Thank you so
Yeah.
much for your time.
Okay. But
Thank you.
anyway, you did great in that. Okay. What I will go through now for all of you, doctor, please, as I told you, please bring a piece of paper and pen, and let's discuss. I will try to go fast through how to approach a case of fatigue. Okay, and when you have this algorithm, and usually when you have this algorithm, you won't be worried about what can be found in the exam, at least the common cases. I won't say an algorithm will be like covering 100 of 100 cases, but at least knowing the approach of how to approach these cases will make it way easier for you whenever you face this case. So for the doctor asking me on the chat about the headache, I have a full lecture about headache on my Teachable site in the link I sent you. And you will also find it on the YouTube for the headache. I have a full algorithm for how to approach headache, because in general, if the case is headache, you need to approach through what was discussed in the headache lecture, okay? So here, please focus with me in the coming 10 minutes, because there will be this algorithm, and please don't leave before we finish, because I will be discussing many other details, okay? So this is my algorithm for the fatigue and tiredness, fatigue, and generalized weakness. And this is not for localized weakness. I mean, this is not the approach when the patient has like a left side weakness or hand weakness or lower limb weakness. It's different approach when it is localized. But for generalized weakness, you will go through what I'm discussing now. Usually in any algorithm, we start by what is called the yellow questions. And when I talk about the yellow questions, are the questions that you need to ask early in order to reach some hidden things in the case. So usually for any symptoms in general, if it is not pain, you will ask about onset, course, and duration. And what do you mean by the fatigue? Or what do you mean by any symptoms that the patient asking, and giving the patient the chance to describe the symptoms by his own language, or her own language usually helps you, because she might say something that really guides you toward the correct diagnosis. And the other question that you need to ask early, and this is what the Dr. Ryan did, is what the time in the day. And this is these two questions, what the time of the day and weight change recently, both of these two questions will guide you toward the hidden diagnosis in the case, okay? And remember, in the last years, they are trying to mix two diagnoses together. So please don't be happy that you reach systemic sclerosis, for example, and forget to ask, or systemic lupus, and forget to think about the mixed connective tissue disease. And when you have a case like what we discussed today, it's not enough to reach its hypothyroidism. You need to reach it as postpartum thyroiditis, like what Dr. Ryan did, and also having obstructive sleep apnea. If you didn't ask about, you will be forgetting a main part or major part of the case. And also this will affect your plan of management, because you will forget to ask about sleep study, you will forget to do the echo, you will forget to do all these things related to the diagnosis that you might miss. So the first, look at the screen, what time in the day, and this will help you. I won't say again, you need to ask about most of the diagnoses I'm going to discuss in the history. Maybe in station 5, you need to be more concise, but in the history, please go through this pathway. So what's the time of the day? Is it the morning? Is it all the day? Or is it by the end of the day? When it is in the morning, you will ask the 4 questions of the obstructive sleep apnea. And just to remember them, if you don't know, obstructive sleep apnea is very, very common in the exam. So with any weight gain or with any fatigue, okay, with any problem in erectile dysfunction with male and loss of libido in females, you need please to consider obstructive sleep apnea. It's a very high yield topic in the PACES exam. So remember, in the obstructive sleep apnea, we ask 4 questions and we examine 3 things. Okay, so the 4 questions of obstructive sleep apnea we divide through the day. Okay, what I mean by that, you will ask something in the morning, something happening during the day, something happened just before sleeping, and something happened during sleeping. This will help you to remember the questions. So the 4 things that you will ask, the first thing in the morning is the morning headache and feeling unfresh. So I never woke up fresh. Okay, so the sleep didn't help. We will wake up tired, as if you didn't sleep because you spend the night fighting for air. So in the morning, it's the headache and feeling unfresh. And then during the day, being sleepy or sleepiness or tiredness, sleeping in the front of the TV, sleeping while driving. So this is what's happening during the day. Just before sleeping, remember, it's about the intimate relation. So for the male, it's always erectile dysfunction. And for female, even the loss of libido is part of the obstructive sleep apnea. And during sleep is the snoring and the loud snoring and the gasping for air or waking up gasping for air, which is the apnea. And usually it might be witnessed by the partner as well. So snoring and gasping for air. And sometimes the patient recognizes that him or herself. Okay. So these are the 4 questions for the obstructive sleep apnea. And for examination, you usually, it's just brief, it's not the details, but you will examine 3 things just to remember. Okay, you will examine the patient oral cavity. You need to look for the palate and look for the tongue. So you will, if this is station 5, because usually when I am describing algorithm, you will use it in the history and in station 5 with less details. So you will ask the patient to open his mouth and take a look about his throat, about mouth ulcers, about dryness, about the size of the tongue, the dropped palate, all this stuff. We are not ENT expert, but at least it's part of what you will look for because some of these cases might need surgery at some level. And the other thing is the neck circumference, and you will ask, usually they won't ask you to do that, but you need to ask that you need to examine the circumference of the neck. Usually it's 16.5 to 17 inches for the male, and it's 15.5 to 16 in the female. Okay, this is increased, the increased neck circumference is part of the causes and signs also of the obstructive sleep apnea. And the third thing will be the chest examination, and usually this is for the pulmonary hypertension. And you will expect in pulmonary hypertension to find left peristernal heave. You will find a loud second heart sound. Just to know, I'm sure that you practice that in your clinical practicing, but in general, when you hear the second heart sound and the first heart sound equal in both sides of the chest, okay, this is unusual because the second heart sound is always finer and softer than the first heart sound. But because the pulmonary part of the second heart sound will be attenuated, okay, because of the pulmonary hypertension, you'll feel that the first heart sound and the second heart sound is almost equal in the intensity. And if you heard that 1 or 2 times during practicing, you won't forget it. You might feel it is not that easy, but it is. It shouldn't be. They shouldn't be in the same strength. Okay. Then this is for the obstructive sleep apnea. For the investigation for obstructive sleep apnea, you will need to do sleep study, okay, and you need to do echocardiography, and you need to do to check and monitor the blood pressure, and you need to check the blood sugar as well, because there is risk of hypertension and diabetes with obstructive sleep apnea if untreated. Okay, for the treatment, usually it is you will have the CPAP is the treatment, and weight loss is part of treatment, and also sometimes they use dental appliance that they made it to push the tongue to the front, so allow better breathing during sleeping. So if the case is obstructive sleep apnea, very common in station 5, please remember the 4 questions and the 3 examination, and what are the lab the lab works and the investigations and the procedure you might do for the day, confirm the diagnosis, and what will be the treatment for the obstructive sleep apnea. Okay, very important. Please, I wanted to know that by heart. If the fatigue and give me the okay in the chat box that you are okay with the obstructive sleep apnea. Hello. Okay. Yeah, great. Okay, so please write that. I can't keep repeating the question. That's why I'm telling you. It's written there. You need to write it by your hand. I can't keep repeating them, so please write just after me, okay? Then when the fatigue is all the day, the tiredness is all the day, you need to think more general, okay? And especially if there is no change in the weight. So if there is some changes in the weight, you will go to the right side of the page that I'm going to discuss after a few minutes. But if it is all the day and it's generalized fatigue, just to help you try to remember this mnemonic, which is the 3 SAT. When I'm saying 3 SAT, okay, the 3S refer to, the first S is referred to, I would say stresses, but this is not what I mean by that. Here stresses, I mean, it's more, I'm talking about the chronic fatigue syndrome, and I'm talking about fibromyalgia. We can't consider this stresses, but just to remember, I put it as S just to remind you. For chronic fatigue syndrome, I have a specific slide and specific part I'm always discussing. If the doctor who attended with me the course, we have many cases we practice about fibromyalgia, and a case for fibromyalgia and chronic fatigue syndrome and what's the difference between them. Then I can't go through all the details of the cases today, but at least just to remember, the first is stresses, remember, right, chronic fatigue syndrome and fibromyalgia. The second is for sexually transmitted disease. And why I said that? Because infections in general can cause that, but because they like to bring a case of HIV, and the symptom might be tiredness and fatigue. And when you dig deeper, you'll find travel history and the businessman and the rash and whatever, what they have, recurrent infections. So sexually transmitted disease, okay, and infections in general might be a cause for generalized fatigue. And the third S will be for sclerosis. And here I mean by sclerosis is multiple sclerosis. Just write it, just to remind you, because multiple sclerosis is one of the very common symptoms that the patients start with. Some patients with multiple sclerosis, they just suffer from fatigue and tiredness for a long period. Then they start to get the diagnosis. It won't come in the exam only with tiredness and fatigue. I didn't see that before, but it should be one of your differential. Okay, and it should be, and you should dig to search for that. If the patient has like motor sensory symptoms, if the patient has blurring of vision that starts suddenly, if the patient has symptoms that not going in the regular order, patchy weakness, patchy sensory problems. So the 3 S's are the stresses for the fibromyalgia and chronic fatigue, sexually transmitted disease and infections, and sclerosis for multiple sclerosis. The A for anemia, and I want you to write the mnemonic we used for anemia, which is, this is a big algorithm, so it's not for one case. You will use it for many cases if it came in the exam. So for the A is anemia, and please write what I'm saying now. Write the MAHD. MAHD is the mnemonic we use for anemia. The M referred to malignancy as a cause of anemia. The other M for malabsorption. The third M for melena. The fourth M for menorrhagia. So these are 4 M's for anemia. And then the H refers to hereditary hemorrhagic telangiectasia, and the D referred to diet and drugs, drugs that can cause anemia. Then acute blood loss for sure, and anemia of chronic disease. So all these can be related to anemia, and we also have a lecture, specific lecture for anemia and how to approach a case of anemia and what to see and what to examine. Then the T referred to tumors, and for tumors, you will ask about weight loss, lumps and bumps, and loss of appetite, loss of weight, and all these questions that we used to ask about. The TB and tumors. Usually the TB and tumors, they are related, okay, because they are sharing the night sweat. The B symptoms of the tumors might be similar to the symptoms of the tumors. So ask the question of the bundle 1, if you attend with me before, bundle 1 is the general question for the tumors and the TB. Okay. So the 3 S's, as I said, the ABCD is not, it was my mnemonic for the anemia, but now we change it with MAHD. MAHD make it more easy. Then the T for the TB and tumor. Try to write what these letters refer to. And the one for if the fatigue and tiredness happen by the end of the day, Okay, remember we might be talking about myasthenia gravis, and it came in the exam before. And remember, for myasthenia gravis, it shouldn't be like that. Shouldn't be directly like end of the day fatigue. Okay, it's after the effort. So the patient might say, when I start to do something, I started well, then I start to lose my power doing that. So it won't be that clear at the end of the day, but usually it's at the end of the effort. So the patient might be starting his day very well, and after a while he will feel very tired. After starting doing anything, will be tired. Remember, write with me. I want to be sure that you are still awake. So write in the chat box, what are the symptoms that you expect to see in a patient with myasthenia gravis? What do you expect to find? What do you expect to find in the eye, for example? So for the doctor asking me about ABCD, just change it by MAHD, MHD. MAHD is for the M's I said, and H and D. Okay, yes, correct, Dr. Aya. So Dr. Aya, you all start still chatting with me directly. You can't chat in general, just change your chat to everyone so you can help everyone. So for the eye, there is ptosis, dropping of the eyelid, correct? What about the mouth? What do you expect to find in the mouth? Dr. Yasmin, the M in the anemia refer to malignancy, malabsorption, melena, menorrhagia. Okay, diplopia and ptosis, correct. In the mouth, what do you expect? Dysphonia, agree. Okay, and when you ask the patient to smile, you'll see the myasthenic sneer. I'm smiling, correct? In the speech, there will be nasal speech. In swallow, there might be dysphagia, proximal myopathy as well, correct? Okay, great. And sometimes in the chest, what do you expect to see in a patient with myasthenia gravis? Do you expect to find something other than the shortness of breath and dyspnea? Yeah, exactly. Perfect, Dr. Ryan. Yeah, you might find a star for thymomectomy. Perfect, perfect, wonderful. Okay, so this is for the left side. This is for the left side that you will start your approach with, especially when you don't have a specific problem with the weight, but you still, I mean, the obstructive sleep apnea will be part of your question, whether there is a change in the weight or not. It should be there. So please don't say, okay, Dr. Tan, there were a weight gain or weight loss. That's why I didn't ask about obstructive sleep apnea, because one of the causes of obstructive sleep apnea are weight gain as well. Okay, but still obstructive sleep apnea can happen without the weight gain, okay? So you will ask all the algorithm, okay, but you don't need to ask the question of the weight loss if there is no weight loss, but the left part, you need to ask for all of it. And then when we are talking about weight change, remember, for the weight gain, if you attend with me before, or if you attend our course, we use a mnemonic for the weight gain, which is the FRCP as PhD increases weight. So the FRCP as PhD increases weight. And I will tell you what this mnemonic referred to in the next slide, okay? But for now, just remember it. But when we have a weight gain, the next question will be always what the distribution of this weight gain. Is it central weight gain, which is going with the Cushing syndrome? Please write in the chat box, what are the screening question? What are the screening questions for the Cushing syndrome? Write in the chat box, please. Okay, easy paresis, I agree. This is one. What else? Screening question, I don't need the details. Screening questions. Stria, great. So we call it stretch marks. We call it stretch marks. Proximal myopathy, I agree. We said, okay, stretch marks. We call it stretch marks. So the distribution, the easy paresis, the proximal myopathy, okay, and the stretch marks. These are the general questions. There will be never mention buffalo hump. Forget this word, doctor. The doctor who wrote buffalo hump. Okay, forget this word from your dictionary, please. If you mention this word to the patient or to the examiner, you might fail the station because of the farewell. Okay. Yes, I agree. But remember, doctors, it seems from your question, you don't know what I mean by screening questions. Screening questions are the fast, quick 3 questions that you will be asking just to exclude the diagnosis. Okay. So don't ask, when I say screening question, are the fast, quick question that will exclude. So if it is a central, I will ask about easy paresis. I will ask about the central obesity, the distribution. I will ask about the proximal myopathy. I will ask about the stretch marks. Okay, then the next after the central obesity, if it is not Cushing, we have also a full case of Cushing. We might discuss it in another lecture. If the weight increase in the general body, but the patient noticed change in the facial character in the hand and the feet size, it might be acromegaly. And again, what are the questions for the acromegaly? You will ask about change in the size of the ring, change of the size of the shoes, change in the facial feature. These are the general questions, the general screening questions. But if the answers were yes, you will go in more details in the questioning. And again, this is what I mean by screening question. Then in the general obesity, you need to remember the hypothyroidism, the simple obesity. So you need to ask about change in the diet habit in general. Okay, stop exercising and all this stuff. And the polycystic ovary disease, when the patient with acne, irregular menstruation, abnormal hair distribution in the body. Okay. Dr. Ala is asking about lymphoaton. It was there in the algorithm, the previous algorithm, but I removed it because it never appeared in the exam. Okay, it was there. I used to put it also with the myasthenia gravis to differentiate between them. And we usually ask about the cancer symptoms for that. And I'm explaining it is not as, it's associated with weakness, mainly facial. There is a bladder problem with that, and there is impotence with the lymphoaton, but actually it never appeared in the exam. Okay, that's why and myasthenia gravis is way more important. Okay. So that's why I removed that, but it was in the previous algorithm when I was using, even in my course, it's still there. But now I see it's more confusing than helpful. The SO referred to simple obesity, doctor, for the doctor asking what is the SO, okay? So let's go, I will answer your question after we finish because your question keep like distracting the others. So I will try to answer the questions once we finish, okay? So for the weight gain, the distribution will be your first key, which is central or face and hand and feet or general. And in the general, you will be asking the screening question of all of these. So here, what Dr. Ryan did, she went through the same question. She did great. She went with obstructive sleep apnea. When she found a weight gain and it was general in the body, she went to the thyroid. She found a hypothyroid symptoms. She linked that to the pregnancy and starting the symptom after pregnancy. And just to know, for the hypothyroidism or for the postpartum thyroiditis, it might start with hyperthyroidism symptoms, which is usually very mild and transit for 6 to 12 weeks, sometimes or 6 to 8 weeks. Then the hypothyroid symptoms start. Usually the patient would not need treatment for the, very rare to need treatment for the hypothyroidism, but most of them might need treatment for the hypothyroidism, especially if they're planning to get another pregnancy or something. Okay, so usually 40 to 60% will need treatment for the hypothyroidism that happened in the postpartum thyroiditis. And if the patient has a previous postpartum thyroiditis, the chance to have it again is more than 70%. And when the patient has a high TPO level, anti-TPO level, the chance of having the hypothyroidism is up to 90%. So it's important to know about this as a clinician, not only as an exam candidate, okay? Yes, Dr. Amir, the shadow you see is for the chat, okay? So it is on the left side. It's away from what I'm discussing now, okay? So for the weight loss, you need to ask a question that might help you. Again, I'm trying to make it easier for you. So when there is a weight loss, you need to ask if the appetite is normal or if there is a loss of appetite. When the appetite is normal, just to remember as well, just write that the TP-DM, it's like the TP and diabetes mellitus, but it's TP, not TB. But for the TP, the T here refers to hyperthyroidism. Patient with hyperthyroidism might also has tiredness, okay, might have tiredness as well. Okay, but the appetite might be normal or increased. So when I say normal appetite, I mean it is not decreased. So it can be normal and it can be increased. So patient with hyperthyroidism and with diabetes, they might have a increased in the appetite as well. So normal or increased appetite, hyperthyroidism. So you will ask screening question about hyperthyroidism. Write in the chat box what can be the screening questions for that. Hyperthyroidism. Write in the chat box, please. Let me see again. I just want you to practice asking the hyperthyroidism. Excessive sweating, okay. Weather preference, agree. What else? Shaking hands, agree. Awareness of heartbeat, perfect. That's enough. So these all lost motion as well. So these 4 questions might be very enough for screening. You don't need to go all through these questions, okay? The P referred to what? What can cause a weight loss with P? It might be phychromatocytoma, right? Phychromatocytoma will be with handshakes, excessive sweating, abnormal attacks of hypertension, and it will cause tiredness as well, abnormal blood pressure, normal appetite as well, okay? Then the D referred to, and we have also detailed discussion of the phychromatocytoma in our algorithm for hypertension or abnormal blood pressure, okay? For the D, I'm talking about diabetes mellitus, and you will ask the regular question in diabetes about excessive urination, about the polyuria and the polydipsia and the polyphagia. Then the M referred to malabsorption, okay? How can I ask about malabsorption? Screening question for malabsorption, doctor. I'm waiting for your answers. Okay, skin rash, okay, but it shouldn't all the time be there. Bulky, pale, lost motion, okay. Offensive, difficult to flash, yes, I agree. Lost motion, I agree. Okay, bulky stool, agree. Okay, so difficult, yes, difficult to flash. Anemia as well should be part. Pallor is important question with malabsorption. Lost motion, difficult to flash stool, correct. Sometimes yes, rash and abdominal pain, I agree. Relation to food, I agree. Okay, so these are the things that you will ask about when you have a normal or increased appetite. And you can ask me if malabsorption coming with normal appetite, I'll tell you, yes, patient with celiac disease has a normal appetite. Even patient with inflammatory bowel disease, they might have a normal appetite as well. Some of them will have loss of appetite, but I would say if I am in a history station, I will ask all of them. I mean, I will ask about the appetite and I will ask about all of this. It won't take more than 5 minutes to ask about all this algorithm if you practice that well. So, I mean, you don't need to omit or just don't ask about not to ask about part of the algorithm. Just go and ask about it all and just trying to put your mind in order while you're asking and try to reach your diagnosis. Then if there is a loss of appetite, I will ask about the TIA, and the T here refer to tumor. Again, and you know how to ask about tumor, weight loss and night sweat and lumps and bumps and, you know, all these details. Then infections, okay? Infections, and this is very general. So in infection, you will ask the general questions about fever, about rash, about travel history, about eating from street food, about all these details, because infection is very wide. But infective endocarditis, if the case guide you to infective endocarditis, and again, it has its own details. So you need to ask the patient, usually with severe and serious infection, they will have a loss of appetite. Then the A for Addison disease, and the screening question for Addison disease is feeling dizzy when changing position from sitting to standing or from spine to sitting, okay, or lying down to sitting, okay, presence of pigmentation that might be there if the ACTH is high, okay, which is not always, I mean, it depends on if it is pituitary sources of hypoadrenalism or not, okay, nausea and vomiting as well, okay. So again, what I meant by this algorithm, and this is exactly what we'll discuss our topic, when you have this page, and I remember one of the doctor who told me that he's printing this and try to read them, close your eye and remember this page. In the exam, it will make it for you way easier. You won't miss anything if you follow such algorithm. That's why this is why our course called Algorithmic Paces. It's not about the knowledge. The knowledge is in all the box. I know that you know everything about the details of every disease, but I want you to have this clear, ordered thinking way in order to utilize your time in the best way in your exam, okay? Give me the okay in the chat box that you feel that this algorithm, although sound a little bit long, but it will organize your mind in this case. Give me okay in the chat box so we can go to the next slide. Okay. The P5 chromocytoma, the D diabetes, doctor, for the doctor asking me. Okay. Okay, doctor, this page is the approach for the history, what history approach you like to use. So usually this is the regular approach. And there are many, the approach of the bundles. You can use whatever, don't change your approach. What you used to use, please follow it. And usually what I put here in the order that hi, identify and how and why, I receive a letter from RGB, blah, 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 then evaluate, then analysis of the symptom itself. Don't forget the impact on the life, Dr. Ryan. This is important question. You did everything perfect, but unfortunately, in the mark sheet in the hand of the examiner that I usually discuss before any station in the course. Okay, the impact on life has its own item for the examiner to put marks for. So he should mention something about if your performance was satisfactory or intermediate or unsatisfactory. So if you did everything perfect, but you didn't ask anything about the impact on the life, okay, he won't be able to give you satisfactory in that. So please don't forget the question that you might lose marks. Even in communication history in station 5, the impact on life is very important question. Okay, Dr. Ryan, give me okay in the chat box that you won't forget this one. It's important question to ask, okay? Then you can discuss your differential diagnosis and the affected system and the related system. So this is exactly what I'm saying. I mean, here in this case, what is our affected system mainly? Okay, what can be the affected system here? When you reach that, we are talking about the endocrine. So you can ask the endocrine system and the related autoimmune problems. So this is the main system or the main affection in this case. Then the related system, and this is what Dr. Ryan went through. So let's say if the case is cough, case is respiratory, so the affected system is the pulmonary system, then the main related is the renal, the cardiovascular. So they need to go through all the system review questions, but at least the affected system and the related system might be 1, might be 3 or 4, okay? Then quick relevant system review, should be relevant. You shouldn't keep asking question about nothing. Then you reach the diagnosis, never forget the structure. I mean, never forget the past history, the surgical history, the medical history, the family history, the female history, about menstruation. Don't you think, Dr. Ryan, is important to ask about menstruation in hypothyroid patient? Patient told you that she's a little bit pale and maybe she had a strong, heavy menses, right? So is it important to ask about or not? If you memorize this page, you won't forget asking about menorrhagia as well in hypothyroid patient. Sexual is important as well. And you can say, can I ask you a private question? Because it's also part of the obstructive sleep apnea problem, the loss of libido, right? Social history about the affection on the job. She told you that her husband also complained about snoring. So you need to help her with this thing, right? Yes, let me remove the box. The problem with the black box, this is the chat. What can I do? I want to read what you're saying. Then the travel history as well, then the concern. Dr. Ryan, I will just give us a little comment. Okay, I'm still insisting that you'll get a full mark in this case, but just to remember, don't ask question just after asking the concern. It's very common to happen from the candidate. It's like, can I ask you about your concern? Then when the patient says the concern, instead of answering his concern or her concern, you say, I want to ask you a question because you remember something while she's asking, or you want to ask more question to answer her concerns. So please don't ask a question directly after the concern. Say something and then continue asking. But I mean, what you will say, I appreciate your concern. Your condition might be this or that. Okay, then go to the question you want to ask again. Then say something about, can I ask you more question about that? I have one more question. Can I ask you that? But please don't ask, what's your concern? And after she said the concern, you'll say, can I ask you a question? This is annoying to the examiner and to the examiner might miss your answer for the concern, because he will feel that you ask a question and you forget to answer the concern. So be very concise, okay, in answering the concern, okay? Then the plan of management, give the plan of management, and don't forget the referral. I mean, what you will give, in this case, you should mention that you're going to transfer the patient to the gland doctor, to the sleep medicine doctor, okay? So these are very important. The referrals are very important. You are not the only hero in the hospital, okay? Again, give me the okay that this page might be helpful for you. Whatever what the approach you're using, please add to what you have, whatever is missed from here. For this page, the weight gain, I'm saying this is usually when you have a weight gain, this is also a separate lecture for the weight gain in general. But if you want me to give you this, tell me in the chat box. Do you want me to give you what this referred to, or you become sleepy? Yes or no? I don't like the lecture to be very long, but if you want, it will be based on your request. Yes or no? Yes, yes. Okay. Okay, so start writing what I mean by FRCP as PhD increase weight. I won't say they are all important, but just to remember, if the case is just weight gain, you need to ask IALO questions as well. How much kilograms over how long, the distribution of this weight gain, and the activity or the diet change. If the patient was on diet, if the patient has activity, change in the activity, stop exercising, change the job or whatever. Okay. So let me just, okay, these are the links for the doctor asking for the links. For the FRCP as PhD, okay, these are, just write them, just to remind you, you might add more than what I did, but add this. For the F, just for familial obesity, I mean, the family, they used to be obese. The whole family are obese people, or they're overweight. So you will ask me how to ask this question. The answer might be, they used to be in this weight. Is that familiar in your family, that there's overweight running in the family or something? And this give an idea about the eating habit as well. So the F referred to familial, the R referred to renal failure. And here, when I see renal failure, the hypervolemia, sometimes the patient with hypervolemic status, they weight gain, the edema, they consider the edema as a weight gain, because if you weigh the patient, if you evaluate the ascites relief and the edema relief, you will be weighting the patient and be sure that they are like losing weight. So renal failure and liver failure and heart failure, all of these F, and you can add these if it will make it more easy for you. The F, make it for failure. So the renal failure, in the failure in general, the liver failure with the edema results by hypoalbuminemia, and the heart failure with the hypervolemia, and the families or family history of being overweight. Okay, these are the FR. The C refer to Cushing syndrome, and here the letters in yellow because they are more common in the exam. So the C for Cushing, and remember the screening question: stretch marks, the distribution of the obesity, and easy paresis. The P for polycystic ovary. The screening question is irregular menstruation, hair distribution, and loss of libido as well, and acne. The A refer to acromegaly. The question will be about the facial size of the ring and shoes. Okay. The S refer to stress. Remember, depression, atypical depression associated with weight gain. So you need to ask about the eating habit. Okay. Then the P for pregnancy. So remember to ask about the last period and being sexually active. The H refers to hypothyroidism. Okay. The D refers to drugs, and here write solid. Solids is like a word just to remind you by some medication that increase weight. So remember, steroid, one of the things, Dr. Ryan, in your case, it will be very great if you ask if the patient using a contraceptive or something. It will be very important as well, because with patient with hypothyroidism, it's very urgent to treat the patient. If the patient is not using any contraceptive, if she gets pregnant with the hypothyroidism, it will be serious, and it will affect the baby as well. Okay, so don't forget to ask about contraception and advice about it. The examiner will be very impressed with that. The solid referred to S for steroids, the O for the oral contraceptive pills, the L for lithium, the I for insulin, the D for depression medications like tricyclic and citalopram and all the SSRIs, and the S for sulfonylurea. There are many other medications, but at least the common. I just put some commons. Remember the word solid. And the INC here referred to insulinoma. So patient with hypoglycemia, sometimes, it's not all the time. I mean, insulinoma sometimes associated with weight loss and sometimes associated with weight gain, but I mean, because of the insulin is anabolic hormone, so sometimes it's associated with increased weight, and sometimes it's part of MIN syndrome. Okay, so again, the important are the yellow, the yellow parts, but just to help you remember, whatever what you want to add, again, Dr. Abdul Hay, solid is steroid, O for oral contraceptive pills, L for lithium, I for insulin, D for depression medication, S for sulfonylurea. Okay, if you want to add any medicine, add, but have any other cause of weight gain, add it, but just this can be a good start for you, or this will be covering about 70 or 80% of the weight gain causes that you might need in PACES. That's why in my teaching for PACES, I depend on mnemonics and algorithm, because I really want you to remember one thing here in the history. Whenever you reach the diagnosis, doctor, whenever you reach the diagnosis of acromegaly, spot diagnosis, whatever what you reach, and this is what Dr. Ryan did, confirm your diagnosis by further questions. So you reach it, Dr. Ryan reached the diagnosis of obstructive sleep apnea and hypothyroidism, and she confirmed it by more questions than the screening question, and she did that great. Then ask about the possible etiology, and in this case, she reached two things. For the obstructive sleep apnea, she reached the weight gain, and for the hypothyroidism, she reached the pregnancy and the lymphatic infiltration of the gland that happened in postpartum thyroiditis. So this was great. Association, and this was great, Dr. Ryan, as well, because association of other autoimmune diseases like Addison disease, like diabetes type 1, and all these autoimmune diseases is associated with the presence of autoimmune hypothyroidism. So asking about association. Complication was wonderful when you did that, Dr. Ryan, when you ask about the dysphagia, when you ask about shortness of breath, okay, because when you ask about hoarseness of the voice, because these three symptoms or these three complications are very important with the case of hyperthyroidism, and hyperthyroidism whenever there is goiter, so for the retrosternal extension as well. Then the structure that we said, ask about the past history, social history, and travel history, menstrual history, sexual history, all these details, then answer the concern. So this is the golden circle for the history. If you manage to remember and memorize this in your exam day, this will improve your approach for any case in the exam. Okay. Then nothing, there's just, I will go very fast through. I know you are tired and you want to leave, but now, to be honest, I want to give you everything for the hypothyroidism. Generally, when we practice this algorithm in the course, we go through all the possible cases. So we go in details to Cushing, to hypothyroidism, to myasthenia gravis with all details. So we practice different cases about the same algorithm. So this page for the hypothyroidism giving you details, confirm the diagnosis. This is what I just mentioned. Cold intolerance, constipation, dry skin, weight gain, bradycardia, menorrhagia, depression, and memory problem. Okay, and concentration problem. Okay, when we go to the etiology, it might be infiltrative disease, sarcoidosis, amyloidosis, radioactive iodine, patient exposed to radioactive iodine post for the treatment of hyperthyroidism, previous surgeries, okay, iodine deficiency in countries with iodine deficiency, autoimmune diseases and medications and drugs that might cause hypothyroidism. Complication here, retrosternal extension symptoms, which I just mentioned, okay, proximal myopathy, pleural effusion, and peripheral neuropathy, obstructive sleep apnea, carpal tunnel syndromes. And you asked about most of these questions, doctor, when you ask about the numbness of the limbs and the weakness and all this stuff, and shortness of breath for pleural effusion, then association of Addison, diabetes, vitiligo, other autoimmune problems in general. Okay, so I think, do you think this approach, the last two slides, do you think this is helpful? The way that you analyze anything when you reach the diagnosis, because one of the challenges you might see in the exam, the spot diagnosis case, you go and see acromegaly and you don't know what to do more. So just remember this page, confirm etiology, association, complication, then structure and concern, you will get a full mark. And remember my principle in general, you are not in the exam to pass the test only. You are in the exam not to lose any mark. If your objective is not to lose any mark, you will pass. But if you just want to reach the passing score, you will be at risk. Okay. Then this is just comparing between the hypothyroidism, the primary and secondary. So with the primary, it's usually there's primary means the problem is in the thyroid gland itself. Secondary is related to the pituitary gland. So usually there is a weight gain with the primary. Sometimes it's in the secondary, it's fixed or loss of weight. Then the period there's menorrhagia, but in the secondary there's amenorrhea because the patient will also has a low gonadotropic hormones. Then the goiter, it's usually there in the primary because the TSH, which causes increasing in the size, will be high. The pituitary try to solve the thyroid problem to keep sending the TSH, which increasing the size. But in the secondary, there won't be goiter, but it shouldn't be all the time there, the goiter. But I mean, in secondary, it's very difficult to have. There won't be a goiter because the gland, there is no TSH. The problem is in the low TSH coming from the pituitary. And the pigmentation, you won't expect pigmentation in the primary. It's not related, but it will be depigmented in the areola, okay, if it is in the secondary, because there is less ACTH, because there is hypopituitarism. And we have a clear discussion of a case of hypopituitarism and Sheehan syndrome and all this stuff. Then autoimmune disease, it's association. In the primary, usually there's autoimmune association. In the secondary, it is usually more than radiation, trauma, and bleeding and all this stuff in the pituitary. Okay, I know I'm very fast now, but because this is the detailed case, and I'm sure that you can find the hypothyroidism details anywhere. When I am discussing that as a station 5, usually, okay, you need to know what to examine in the hypothyroidism. So in the face, you will look for the eye buffness, loss of the outer third of the eyebrow, maybe vitiligo and alopecia. In the neck, thyroid exam and lymph node, and extension of the hyperthyroidism of the side of the thyroid gland. You will examine the chest and the abdomen for pleural effusion and ascites. In the hand, you will check the skin and you will find cold, puffy, dry, bradycardia, carpal tunnel syndrome. In the arm, proximal myopathy, you will examine for that. In the leg, delayed ankle jerk reflex and no pitting edema. Okay, and non-pitting edema. And yeah, this is for myasthenia gravis. It's not our case today, but here is what we, I was planning to discuss today. So hopefully you found that helpful. Okay, and just want to show you something again, because I'm not sure if I'm going to, my plan is not to put all the cases on the, just a second, on the YouTube, okay, because the people taking the things and put their names on. Just to know, please look at this screen I'm sharing now. Okay, for this screen, when you just click the link of my course, without joining the course, you have this preview for the free lecture. When you click the link of our course, so you will see this free lectures link. So go there and watch this free lecture, preview of the free lecture. The first 3 is only for the review and success stories of our course. And then these are free lectures. So please preview and watch them. They might ask you to make an account or something, just make everything for free. And if you enjoyed what we are doing and the way we are discussing the cases, when you join the course, you will have the link to start. You have 7 days for station 5 and history in detail, 6 hours or 5 hours a day. Then communication skills, 5 days. Then neurology, full neurology in 2 days. Then 2 more practicing day and extra slides. So when you join the course, you will have this opened. But even without joining the course, you will have this preview 11 lectures to watch. And also you have our YouTube as well. So let me share with you again for the last time now, the links for our course and YouTube and everything. And until January 5, we have 30% discount for the course if you will join. And you will be added to WhatsApp group to discuss any new information or something, or answer your questions. So that's it for today. And hopefully you found that helpful. And I also enjoy being with you, Doctor. And good luck for everyone. Enjoy your journey in PACES. And remember, what you are learning today is not only for the exam, it will help you with approaching your patients, and you will be a different doctor. So remember us in dua, inshallah, when you use any word or learn any word from Al-Abdul Faqir Lillah. Okay? Thank you, doctors. Thank you, and have a wonderful day. If you have any question, please join. Thank you, Dr. Ryan. Please, thank you all the doctors for your nice words. Please send me any question you have on my WhatsApp. And again, this is my WhatsApp number. If you want, let me share it with you for, okay. This is my WhatsApp number, direct WhatsApp number. If you want, feel free to ask me any question about any topic or any question about the exam in general. Okay. Thank you and have a wonderful day, inshallah.